So my mission statement, any good experiment starts with a mission or an aim, but I really want to put across through this concept that decay is diet and oral hygiene and bottled water. It's hopefully by the end of this evening you'll really appreciate it's more towards factors that predispose nocturnal mouth breathing. So where I come from is I blame most of the problems I see dentally not on diet, not on oral hygiene, not on mum's not teaching me how to do things, not being able to have orthodontic treatment when I was younger, but I blame it on an inability to breathe as well through the nose as the mouth. And mouth breathing to me is a bit of a problem. So the way I'll break it down tonight, it's a pretty open forum, and we have Professor Bucks here this evening as well, who's from the Department of Psychology, and Romola would like to have a bit of input as well, which I think would be healthy for all of us. So I plan to break it down into 3 steps. I'll cover the historical aspects of my understanding. I have a bit of a quick break, a few quick questions, then we'll get into contemporary understanding, and then we'll finish it off with the clinical implications. And Alex, what causes that in a wisdom tooth? Where's Alex hiding? Come on, Alex. What causes that in a wisdom tooth?
It's not fully developed, and you're talking about banding? Or
Yeah, no, just the banding.
Banding, so
good man, good fella. Yeah? So that's a good one. Okay, so where I started with this is my interest began about probably 20 years ago. And what I've noticed about sleep bruxism is that it causes most of the problems I see. Pretty well every patient that we see has it. It's not talked about. I think in the time I've been a dentist for 26 years, there's been one course on it, and that was hopeless. It accounts for the majority of our workload, but I think the key thing that we need to appreciate is we're not taught to identify patterns of breakdown in our training. We're taught to look through little circles, and that's because we're taught by people who are trained to look through small circles, namely specialists. We need to have a wider approach to our assessment of patients, and we need to have a broader approach to our understanding. And what came of this for me is I was seeing these patients coming in smashing their teeth up, and I tried to sort of break this down, and I basically determined there were 2 types of bruxas. There were the bruxas that didn't get many problems with their teeth. They might wear them, but they didn't get any aches or pains or decay or TMD or anything like that. And then there was the other cohort, the unstable, what I call the unstable bruxas. And within the unstable bruxas, there were 2 smaller categories, what I call the localised unstable bruxas and the generalised unstable bruxas. And what I've also appreciated in dentistry too is to have success in dentistry, not only should we manage the signs, what the patient presents with, but we've also got to be really vigilant on managing underlying cause. So where it starts is we start with an OPG. And I remember going to a lecture by a prominent Perth endodontist who said in one of his lectures that he felt the OPG was probably one of the most useless radiographs that we could have. Now that was only 5 years ago, professor in endodontics. Now I'm not criticising him, but I'm challenging him because I would disagree. The advantage with an OPG is it's a screener. And as we can see on here, and I've indicated it, you know, this young patient came in and they've got the same teeth left and right with breakdown. What we call localised bilateral breakdown. You've got to say, well, why? Why has that happened in a 16-year-old girl? But you don't often see that pattern with an intraoral film, particularly if you only take one. And let's face it, a lot of this decay we don't see because of the hardening effects of fluoride. So fluoride hardens the outside, makes teeth acid resistant, but it doesn't make them crack resistant. And it affords no protection at all to dentine. So all the bugs have got to do is get through a crack and they're away. The problem is the fluoride is masking that breakdown. So here we're trained that fluoride's the holy grail. Well, in one camp it might be, but it's also masking breakdown caused through sleep bruxism. So OPGs are crucial. And so through that, I basically got these patterns. And what I found was a stable bruxa, and I'm a stable bruxa. Basically, these patients basically all had a few things in common. Essentially, they'd had very little, if any, dentistry done to them. They hadn't had orthodontic treatment. They hadn't had teeth removed. They hadn't had teeth weakened by restorations. And essentially what I would do with these patients is I'd manage their bruxism using splints, thinking that I was helping them, and then I'd wait until they're stable on the splints, and then I'd mount up their casts, and I'd have a look at their occlusion, and I'd find pretty well that CO equals CR. RLAR, maximum intercuspation, fitted with musculo-occlusal stability. So forces were well distributed in these patients. And so these were the stable bruxas. Excuse a few of these slides, because this is going back 20 years. That's when I started to collate this stuff. So, you know, all these patients had full set of teeth. I've put a few little indicators there for your serrated gonial angles, which I'll talk more about down the track, and also the yellow indicator at the top, where we'll talk about deviated nasal septums. At that stage, we weren't even looking above the hard palate. Why? Because the OPGs, the field of view, didn't even include the sinus. Fortunately now the OPGs do. So all these patients were the same. They'd had bugger all dentistry done, their teeth were all good, and that some of them might not have seen a dentist in 6 years. All the same. Then with the unstable group, the patients who came in who did have breakdown from bruxism, they were different in that they had had a history of dental intervention. They had had more than 6 restorations, they had had orthodontic treatment. I mean, we're all told, you know, you've got to have orthodontic treatment to have dentition for life. To me, that's bullshit. I was training to be an orthodontist, and I really questioned then what I was learning, and that's why I didn't become one. And so with these patients, what I found is I'd make them a splint, not really knowing what I was doing, but that was my training. And I'd wait until they'd stabilised in a splint, and I'd mount their casts up, and sure enough, we did see a tooth jaw joint argument where CO and CR didn't correlate. There was a slide. So in musculoskeletal position, the occlusion didn't match. And yes, we had unfavourable loading. And so when we see these patients, this is what we would see. We would see the caries, and then lo and behold, maybe a similar spot on the other side would have been lost maybe a few years before. No one had questioned that. They would just pull out the tooth and send them on their merry way. And the same, I mean, look at that, that's a mirror image. Now, who in their right mind would say that's caused by wisdom teeth? There'd be some people in this room that might. That patient was diagnosed with severe apnea 15 years later, because this is in 1995. So 15 years later, she's now been diagnosed with severe apnea. She hates going to the dentist. She hates anyone in her mouth. And I'll talk more about that as well. And again, you'll see this, where one tooth is just eaten out and neighbouring teeth aren't touched. But you've got to ask the question, why? And so we see these things you'll all see, except Romola, but it's good to appreciate how it works. So we'll get these localised areas of breakdown. And some people would blame this on poor diet and poor oral hygiene. Well, if it's poor diet and oral hygiene, it's going to be affecting all of them the same. Why is it that one surface on one tooth gets the breakdown? And what we're seeing here is we're seeing the effects of force concentration within teeth. And often where we see the force concentration is diagonally opposite to where the interference is on a tooth. So what you start to look for is where the interference is on a tooth or a high spot, be it in balancing or working or centric, and you'll find the decay diagonally opposite that spot, because that's where the stresses concentrate. That's where the cracks appear, and in go the bugs. With the unstable bruxas, of course, that's common sense. When we see generalised breakdown, well, here we've got generalised factors operating. So now we've got bruxism superimposed with, you know, patients who don't clean, there might be polypharmacy, there might be all these other issues. And so the generalised breakdowns are obvious. And we're not really so interested in those. We're interested in the localised breakdown category. And again, the generalised is blunderblust, it's everywhere. So therefore we've got a generalised cause. So you'll get that from an OPG, but you won't get it from a periapical film. So I always start with OPGs. When you see a patient for the first time, it's an OPG. It's not a bite wing or a periapical. Start with an OPG. So it helps you to recognise patterns of breakdown. We need to appreciate that the teeth and the muscles and the joints, they all develop as a family. If they're not interfered with, you'll find that these patients get very, very few problems with their teeth because of bruxism. Because bruxism is normal. Everyone in this room does it. And the people who get very few problems from it will generally be the patients who have had bugger all done to their teeth. But when we start to extract teeth and fill teeth, because that's not meant to happen, God didn't make us to have teeth pulled out. God didn't make us to have root canals. That's something that we're trained to do because we're taught that that is right. Is it? And the other thing I want you to appreciate here too is when you do see breakdown in a tooth, go back 3 years, what I call my 3-year window. And fundamentally what that says, it takes 3 years from the time that the insult occurs, when the bruxism really kicks in, to the time when you start to get your clinical presentations. So most of those fluoride bombs and things like that you see, they're 3 years in the making, and that's very, very important. Because if you can correlate this with patients, they're going to love you. And you'll be telling them things that they haven't surrendered to you. And you've got all of that off an X-ray, and they're going to think you're pretty damn good. So the traditional understanding with bruxism, when I was trained in the 80s, it was, you know, let's equilibrate, let's occlusion, let's equilibrate, let's level these puppies. And we understood that just made them worse. So it wasn't peripheral theory, and that is dispelled. So anyone out there who's touching teeth to stop bruxism, you should be shot. Then it moved on, less, it's the centralised theory. And the centralised theory then came from the concepts of stress. And remember, with stress, we have a physical stress and we have a what I call a psychosocial stress. And Rommel will probably pick me up on that afterwards, but that's the way I look at it. But, you know, people who go to the gym and work out a lot, that's a physical stress as opposed to, you know, my wife's leaving me or I got a sick kid or whatever. That's the other sort of stress. We understood that there was respiratory interplay. How this was happening we didn't know, but the people who did have sleep disordered breathing, which we didn't appreciate a lot of at the time, but it might have been asthma, like I'm an asthmatic and I'm a shocking grinder. We understood the connection, but we didn't really, well, we understood the connection between that condition and bruxism, but we didn't really understand why. We knew if people went through hormonal change, your pubertal growth spurt, menopause, fertility treatment, you'll start to grind like hell. We didn't really know why, but we knew it was centrally mediated. Environmental factors like drugs and alcohol and caffeine. So when you go to a lecture on bruxism, this is what these guys spit out. But the problem with it is you're having to remember all these things. And the irony is you don't have to, which I'll come to. There's a common connector with all of these things, and that's what we call is sleep arousal. We also appreciated that there are awake and sleep variants, and they are two totally different animals, so we don't confuse the two. Sleep bruxism is the beast. Why? Because of the forces associated with it, and we're out to it. We can't control it. Awake bruxism, different etiology, concentration, stress, these sorts of things, anger, but the forces are much less, and patients can control it. So we're not worried about that. Awake bruxism doesn't cause our headaches. So bruxism is Bryken for Greek, right? And the traditional definition, and I'm working up until 2005 here, was that it was classified, well actually here, this is 2014 that I've popped in here, but originally it was classified as a parasomnia, then it was classified as a sleep-related movement disorder, and now it's being just classified as sleep-related bruxism, because we understand that there's awake variances as well. It has to be differentiated from a few beasts, and so when you get interested in bruxism, you automatically have to become interested in sleep. And this is the irony, really, as dentists, we should be very much focusing on sleep. Most of the work that we have to do during the day is caused by what's happening in the other third of the day, and that's while patients are asleep. So there are a few little things there like faciomandibular myoclonus that can be associated with some nasty things, REM sleep behaviour disorder and a few others. But typically speaking, that can be picked up in a laboratory-based sleep study. We understand that most sleep bruxism occurs in stage 2, non-REM stage 2, that stands for. And you're all familiar with all the sleep stages, so I'm not going to go over that, because Mark over there reckons you all are. And the prevalence I question a little bit, and this is the problem with studies, because a lot of the studies weren't comparing apples with apples because they didn't really know what they were looking for, and the other problem with it is that the research criteria for sleep bruxism was very poorly quantified. So it's very, very hard to compare one study with another. And that fortunately changed, which I'll come to shortly. How do we diagnose it? Well, with the traditional classifications up until 2005, we would use questionnaires. They have pluses and minuses. We would probably look at the patient clinically as well. You know, are you grinding your teeth? I remember going to a lecture by Dr. Delcano, And Dr. Calcano got up there and he was talking on sleep bruxism about 3 years ago, and the diagnosis for sleep bruxism was you're grinding your teeth. The patient is aware of grinding their teeth or making noises in their sleep. They get a sore jaw when they wake in the morning and their muscles are a little bit big. Give me a break. I'm going to show you stuff with bruxism you've never even connected before. And these guys are the specialists. So just because you're a generalist, you're lucky because you know more. Or at least you're going to make an effort to know more. Don't get focused on the small circles. Little used classification that I started off using in 1990, very simple. When I look in a mouth, no signs or symptoms. Type 1. Type 2, there's just signs, a bit of cheek biting, you know, wear on teeth, things like that, maybe a bit of decay. And number 3 was signs and symptoms. So these are things that you can start to include in your medical dental history straight off. And what's the significance? A lot of this stuff you're already aware of, but the forces are astronomical. So again, if we bite as hard as we can and we times it by 3 and we maintain those forces for 5 to 10 second bursts in our sleep, that's what we're dealing with. Huge forces, massive forces. They're non-actual, they're all off centre, particularly if, when we brux, we always go to that musculoskeletal position. And if the occlusion is not concentric with that, then some teeth are going to get a hell of a lot more load than others. And of course, they're the ones that fall to bits. So then we get the flexion, then we get the fatigue, then we get the cracks, and then we get the decay. And that's what I call history of dental intervention. We obviously get the retrograde wear. We understand the condition is more unilateral than bilateral, and it usually affects the top jaw more than the bottom. And the reason for that, come through guys. Sorry. You can sit down here on the floor in front of me. The main reason for that is the differential in force dissipation between the top jaw and the lower jaw. So the lower jaw, being a mandible, is an independent bone and it can flex. It can dissipate force. It's the same reason why you take an impression with the patient open wide and you pour up the model, and you take an impression of the same patient with their mouth virtually closed, and you compare the two models, they're not the same. So the maxilla has got very little give. It's bolted to the skull in 3 places, and the tuberosity is in the septum, and therefore the teeth take more load. And obviously it's going to be teeth under lines of force, but sometimes teeth with small cross-sectional areas. So lateral incisors, particularly upper lateral incisors, a little bit of a red flag. Be mindful of that. And most of these patients do have some level of TMD and osteoarthritis of their joints, which I'm not going to really go on tonight. That's another lecture in itself. So what did I correlate in the 90s? Well, these were all the medical conditions that I was finding that all these bruxers with localised advanced breakdown had, and generalised bruxism without too many problems. But these were all these medical conditions. They had type 2 diabetes, they might have had depression, there might have been anxiety, they might have had gut problems, chronic fatigue, Lyme disease. I didn't even know what Lyme disease was. Bedwetting at night, erectile dysfunction. I only picked that up because of the medications they were on. Things like Cialis, you know, as a red flag in a male. Take that one home tonight. And testosterone is a red flag in a male. And fibromyalgia. But again, I didn't understand the connector here. So I was just correlating this. The signs and the symptoms intraorally, I'm not going to go through all of these, but a few of the key things, obviously the cracks, the abfractions, which are the flexion lesions. We get the pulpal complications through micro cracks letting in bugs and getting into the pulp. You get your scalloping of the tongue. We appreciate that now because that tongue is pushed forward in our sleep and it's pressed against the inside of the teeth. Distal drift of premolars is a bit of a red flag for me. So if I see 5s going backwards, that's a bruxa. Increased trabeculation. These people are nasty to pull out teeth on. You know, if you're going to have a bad time pulling out a tooth, it's going to be on a bruxa because their bone is like rock. Ectopic eruption of teeth, palatally displaced canines. You know, how often do we see that, but how often have we correlated palatally displaced canines or even ectopic upper sixes, eating out the distal of E's, with mouth breathing? Invasive cervical resorption. Try and read some of the literature on that. The only connector with that by Heathersay in Adelaide was there is a strong correlation with orthodontic treatment. But there's not much else. To me, invasive cervical resorption, which I'll talk about in a minute, is really the soft tissue equivalent of ankylosis. So when that cementum is lost at the dentogingival cuff, before we get to the alveolar bone level, that dentogingival tissue will see the tooth